Hi, good day class. Today we'll continue our discussion on research design. And just a little review of what we discussed last time. We told you that there are two types of research design, basically the descriptive and then the analytic. And then we said that these types of descriptive studies are case report, case series, cross-sectional study, and ecologic study. And then the descriptive studies do not intend to determine relationship, because when a study looks into relationship, there that will now become an analytic study. And then there are two types of analytic studies: the observational and then the experimental. And then we told you that under observational studies, again, we have the cross-sectional study. So a cross-sectional study can be both descriptive and analytic. If a cross-sectional study does not intend to determine relationship, the cross-sectional study is a descriptive study. But if a cross-sectional study intends to look into the relationship, then of two variables, then that cross-sectional study is an analytic study. And then another type of analytic observational study is case control and cohort study. But we just discussed last time cross-sectional and cohort study, and now we will discuss cross-section case control study. So this is the case control study. That's a type of study that attempts to capture the advantages of both the cross-sectional study and the cohort study. You see, an advantage of a cross-sectional study over a cohort study is that, well, the cohort study, let me begin by saying that the cohort study is a better observational study than a cross-sectional study, because we told you that a cross-sectional study has a bias which we call, if you can recall, temporal ambiguity, meaning we do not know which caused which. But a cohort study, really, we can make a valid conclusion as to cause and effect relationship, because a cohort study begins with, as we said, the exposure without the disease, and then we follow them up for a period of time to determine who among people who are exposed develops the disease, who among the unexposed develop the disease. And so we told you that there is no temporal ambiguity with a cohort study, and that is the reason why we can talk of risks for a disease in a cross-sectional study. But one advantage of a cross-sectional study over a cohort study is that a cross-sectional study, while it has temporal ambiguity, can be quickly finished, because we are just looking into the population, the exposed and the unexposed at one point in time, then we're done. Whereas in a cohort study, we will have to follow up for people who will develop the disease among the exposed versus the unexposed, so that in terms of facility, in terms of ease of data collection, where you want to finish a paper quickly, and then a cross-sectional study in that sense has an advantage over a cohort study. But of course, as we said a while ago, a cohort study is a better study design, except that it takes a lot of time for us to finish a cohort study. Some people ask me, how long do I follow up? And then I ask them, how long will the disease develop? after an exposure. They say 5 years, then you will have to follow up for 5 years, that long. So a cohort study really will take a lot of time before you can finish the study. And so we will now talk of a case control study. As we said, it attempts to capture the advantages of both the cross-sectional study and the cohort study. It will hasten the study and at the same time remove temporal ambiguity. So it tries to eliminate temporal ambiguity of the cross-sectional study while at the same time shorten the duration of the study. In a case control study, we select the cases from a target population. So as we said, I don't know if I emphasize this to you, that in a research, when we talk of case, we mean the disease. So cases are a group of people with the outcome or with the disease. People who have the disease are called cases. And then select another group of individuals without the outcome, we call them controls. So that when in a case control study, we go back in time retrospectively to determine the exposure in the cases and in the control. And that's the reason why a lot of people many years ago talk of a retrospective study design. They mean a case control study, and then they say a prospective study design, and they mean a cohort study. But of course now we don't use the word retrospective study design and a prospective study design, because we can have a cohort study that is retrospective, but that's not the we won't discuss that in this class. Okay, now in a case control study, as we said, we compare the exposure status among the cases and among the control. And so we have this group of people, people who have the disease. So we group them into those who have the disease and those who don't have the disease. This is the D bar. People who have the disease are called the cases, and people who don't have the disease, this is the E bar. This is the D bar, I should say. And then we go back retrospectively in time to determine who among the people with the disease were exposed, were not exposed, E bar, who among the people who don't have the disease in the control were exposed and were not exposed, the E bar. So this is a case control study. Now, in a case control study, the measure of the disease is what we call the odds of the disease. And then we compare the odds of the disease among the exposed versus the unexposed. Okay, now this is the formula for the odds of the disease. The odds of the disease are people who are, these are the people who have the disease, and people, the B, are people who don't have the disease among the exposed. Among the exposed, the A and the B are people who are exposed. So odds of the disease has this formula: people with the disease divided by people without the disease. So if you look at the 2x2 table that we've been talking about last time, so these are the people who have the disease A and people who don't have the disease B among the exposed. And this is also the odds of the disease among the unexposed. So the C are people who have the disease, and D are people who don't have the disease among the unexposed. So again, the 2x2 table, people with the disease, people who don't have the disease among the unexposed. And then we compare the odds of the disease between the two exposure groups by getting the ratio. Again, the two exposure groups are people who are exposed and people who are not exposed. We talk of odds of the disease. And this is the formula: the odds of the disease. In the numerator, we have the odds of the disease among the exposed, and in the denominator, we have the odds of the disease among the unexposed, and the ratio is called the odds ratio, or OR, the odds ratio. Okay, so again, this is the table that we showed to you last time. We will calculate the odds ratio for this particular study. We will calculate for the odds ratio. So the odds ratio is calculated as 48. The odds ratio is 4.8. If we just go back to our table, so this is the number of people, 67 divided by 55, that will be the numerator, and then 39 divided by 154, that will be the denominator. And if you look into the odds ratio, the odds ratio will be equal to 2.8. That's the odds ratio. 4.8, I should say. Now, let's talk of the interpretation. If the study is a prevalence study or a cross-sectional study, because just go back to the result. If this is a cohort study, you will note that in a cohort study and in a cross-sectional study, the value will be the same. The risk ratio and the prevalence ratio will be the same, 2.7. But the odds ratio will be different, 4.8. And then the interpretation will be, this is the interpretation, if this is a cross-sectional study, okay, those who have history of hypertension have the prevalence of stroke more than 2 times compared to those who do not have history of hypertension. Now, if this is a cohort study, then we say that those who have hypertension have 2 times the risk. So we talk of risk in a cohort study, more than 2 times the risk of developing stroke compared to those who do not have history of hypertension. But if this is a case-controlled study, this is how you interpret it. Those who have history of hypertension have close to 5 times. The odds ratio is more than 4, so close to 5 times the odds of developing stroke compared to those who do not have history of hypertension. Now, you will note that with odds ratio or with the risk ratio or prevalence ratio, computers will also calculate for, or statistical software will also calculate for the confidence interval. Here, the confidence interval of the odds ratio has a lower limit, has an upper limit, just like a risk ratio or a prevalence ratio. It also has a lower limit and an upper limit. Okay, now notice that if the 95% confidence interval both exclude 1, then the relationship is statistically significant. So in this particular instance, from 2.9 to 7.9, this excludes, the 2 exclude 1, because 1 is here, so 1 and then 2, so from 2.9 to 7, it's already past 1, and so this is statistically significant. If you look at the risk ratio, again, this is already past 1, because 1 is the null value, as we said. Okay, now, so if the 95% confidence interval excludes the null value, the relationship is statistically significant. Now, I would like to show to you here a forest plot. If this is a forest plot, you will note that in a forest plot we have the different, we normally talk of different studies in a forest plot. Each of this is a study, so we have 10 studies here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 studies. Okay, and for each study we have the odds ratio or the risk ratio depending on what the study design is. Okay, so if this is the odds ratio, or the risk ratio, the estimate will always be at the middle. So this is the odds ratio, this is the odds ratio, the odds ratio for these studies, this is the odds ratio, and then this is the 95% confidence interval. This is the lower limit and the upper limit. This is the lower limit and the upper limit. You will note that in this particular study, the odds ratio or the risk ratio is below 1. So about 0.7, say 0.7, and the lower limit is about 0.4, and the upper limit is about 1.2. So the lower limit is from 0.4 to 1.2. You will note that that will include the confidence interval, the range of values will include the null value, so this is not statistically significant. But if you notice this one, the risk ratio here is about 0.4, risk ratio is about 0.4, and then the lower limit is about 0.3, and the upper limit is about 0.6. So from 0.3 to 0.6, it does not, the range does not include 1, so this is significant, statistically significant. And this one has a risk ratio of about 1.2 more or less, and then the lower limit is less than 1, so this is about 0.8, and then the upper limit is about 2.1. So from 0.8 to 2.1, it included, the range included the null value is, we call this also the line of unity. So if this range touches the line of unity, which is 1, and then the relationship is not significant. This one, this is significant, and this one, this is the lower limit, and then the upper limit, and this is the lower limit and the upper limit. So both of these are statistically significant. This one is not, and then this one is statistically significant. This one is not, and this one is statistically significant. And this is actually the summary, the average of all these 10 studies in a diamond. Some of you may be wondering why we have some squares or some rectangles are small, others are big, and then the confidence interval, the range of the confidence interval, some are wide and some are narrow. Okay, now you see the size of the rectangle is dependent on the sample size. The larger the sample size, the bigger will be the rectangle. If the sample size is smaller, then the rectangle will be small. And if the sample size is small, the range will be wide. So you will note that this one has a very narrow range because the sample size is big. Okay, this one is also narrow because the sample size is big. This one is narrow, the sample size is big. But if you note, this one has a small sample size, and that is why the 95% confidence interval is wide. And this one is the average. You add all those, it's not actually the average, you add all the sample size for each of these 10 studies, and then you come up with a very large sample size, and that's the reason why this, the lower limit, and then the upper limit, okay, and then the estimate, the middle will be the estimate, the risk ratio, the 95% confidence interval. So this is actually a forest plot for the next study that we will now talk, which is experimental studies. And this is also known as interventional study, and a study involving intentional change in some characteristics of the study participants. You will note a while ago that we talked of cross-sectional study, cohort study, and a case control study. These are observational study. We don't do anything to the participants. We just observe them. That is why we call them observational studies. In experimental studies, however, there is an intentional change in the characteristics, some characteristics of the study participants. There is an intervention. That is why it is also called an interventional study. And it involves introduction of a drug. So you give a drug or a therapeutic regimen, a program, a health education, a preventive measure like vaccines, or a procedure. So when we intentionally change some characteristics of the study participants, the study becomes an experimental or an interventional study. The experimental studies provide the strongest evidence of causal relationship of all the study designs that we have mentioned, or observational studies, even the strongest in observational studies, the one that provides the strongest evidence of causal relationship is the cohort study, but an experimental study provides even stronger evidence than a cohort study because it affords the most control of the study situation. You can actually control the study situation in an experimental study because it enables the researcher to isolate the effect of the exposure or the intervention. Isolate the effect of the intervention or the exposure. And how does the researcher isolate the effect of the exposure or the intervention? So the researcher chooses a study population without the outcome, very much like a cohort study. We begin with people without the outcome, and then we assign the subjects into two groups by a scientific technique actually called randomization. And the researcher introduces the intervention to one group and then withhold it from another group by giving the placebo. So an interventional study, for example, can give an intervention to one group and then withhold it from another group. Okay, and there are two types of experimental studies. The true experiment and then the quasi experiment. In a true experiment, there is randomization in the allocation of treatment. In a quasi experiment, there is no randomization. Just going back to the one that I told you about assigning the subjects into two groups by a scientific technique, and why does an experimental study provide the strongest evidence? The reason for that is that with randomization, we ensure the characteristics of the two groups equal. So there are two groups, people given the intervention, one group, and then the other group not given the intervention. And then when you assign the two groups with treatment using a scientific technique called randomization, if the sample size is fairly large, we actually ensure that the characteristics of the two groups, the one given the intervention and the one given the not given the intervention, will be more or less the same, because we have the same characteristics in the two groups, and the only difference is that the one is given the intervention and the other one is given the placebo. Because that's the only difference between the two groups, should there be a difference in the outcome, we attribute the difference to the intervention, not to the difference in the characteristics between the two groups, because as we said, the characteristics of the two groups are equal. Because if the characteristics of the two groups are not equal, meaning one group, for example, has much more severe disease than in people given the placebo, for example, have much poorer prognosis than people given the intervention. And should there be a difference in the result, and then we attribute the difference to the drug, to the intervention. And so we said that there are two types of experimental studies: the true experiment, where there is randomization, and with randomization, as I said, we make the characteristics of the two groups equal, and in quasi-experiment, there is no randomization. Now, we'll talk of true experiments where there is randomization. So we have randomized controlled trials. Participants are randomly assigned to groups, usually one study group and another a control group. So the control many times can be a placebo if the disease has no known treatment yet. And the study group receives a treatment, the control does not. The treatment can be an experimental, preventive, or a therapeutic procedure, maneuver, or intervention. Results are assessed by comparison of the outcome in the study group and in the control group. So you now compare the outcome in the study group, in the interventional group, those given the intervention and those not given the intervention. This is a randomized controlled trial. Now, we can also have a preventive clinical trial that uses this is used to test the effectiveness of a preventive measure. So it can be, for example, a vaccine. Intervention clinical trial manages risk factors to prevent the occurrence of a disease for which a factor is known to cause. So, for example, if you want to manage smoking, so smoking, so you want to make an intervention clinical trial that will manage smoking. A therapeutic clinical trial is used to test the effectiveness of a treatment, drug, procedures to arrest the disease problems. Now, so let's talk of a therapeutic clinical trial, and it is most commonly known as a randomized clinical trial, many times a randomized controlled clinical trial. And a randomized clinical trial, controlled trial, is normally conducted in 4 phases, with phase 1 to phase 4, and each phase is treated as a separate trial, and drug development process will normally proceed through all 4 phases. I will discuss to you these different phases, but very quickly, because I would like to think that this will be discussed to you later on when you go to the second year in pharmacology. Okay, so a phase 1 clinical trial is a single sub-therapeutic dose of a study. A single sub-therapeutic doses of the study are given to a small number of subjects, up to 15 participants. And the dose is sub-therapeutic because it only gathers the preliminary data on drugs pharmacodynamics, that means what the drug does to the body, and the pharmacokinetics, what the body does to the drug. And it determines, it documents the ADME, the absorption, distribution, metabolism, and excretion of the drug. Because, as we said, we are talking of a sub-therapeutic dose, a phase 1 clinical trial will only get people who are healthy individuals. In a phase 2 clinical trial, this is tested with a much larger group, up to 80, to evaluate now the safety. And it will determine the safe dosage ranges, and it will identify somehow side effects of the drug. But the side effects of the drug could be subtle and long term and may only happen with only a few people. And because we only have up to 80 people in a phase 2 clinical trial, a phase 2 clinical trial is not expected to identify all side effects. In a clinical trial, in a phase 3 clinical trial, this is now aimed at establishing the efficacy of the drug, and usually against a placebo. And it is tested with a much larger group of people, up to 300 or even beyond, to see if it is effective and to further evaluate its safety. A gradual increase in the sample size allows one for less common side effects to be progressively sought that are not seen in the phase 2 clinical trial. And this is more commonly studied as a randomized controlled trial. And there is randomization. The study group receives the new treatment, the control does not. Or the control group receives a placebo. Only if the disease has no known treatment yet. The control group may also receive a standard treatment. And there is blinding That is usually done to prevent bias in the reporting of the outcomes. We have what we call the single blind, where only the subjects are unaware of the treatment that they receive, and double blind, where both the subjects and the investigators are unaware, I should say, of the treatment the subjects are getting. So this is a double blind controlled trial. Now, phase 4 clinical trial is also called the PMS, or a post-marketing studies or post-marketing surveillance. It serves as the final confirmation of the safety and efficacy, and it is now tested with a much larger groups of people, up to 3,000, to confirm its effectiveness, to monitor side effects, compare it to commonly used treatments, and collect information that will allow it to be used safely. Okay, now let's talk very quickly of a quasi-experimental design. There is no randomization here in the allocation of treatment, and most community trials are done using this type of the study design. An example of a community trial testing the efficacy of fluoridation for drinking water in preventing tooth decay. Two comparable cities in New York State in 1940s, Newburgh and Kingston, were compared for the occurrence of tooth decay and related dental problems in children. Newburgh received fluoride for about 1 decade, Kingston did not. After 10 years in Newburgh, the incidence of dental problems decreased by about half compared to the period prior to fluoridation. In Kingston, dental problems slightly increased. And this particular study utilized a quasi-experimental study, since subjects, and we are talking here of cities, were assigned to treatment arbitrarily and not randomly. Now, other classification by study design, we have what we call the parallel group. This is very much like a randomized controlled trial where each participant is randomly assigned to a group. All participants in the group will either receive or will not receive the intervention. That's actually the randomized controlled trial. There is also a crossover, meaning over time each participant receives or does not receive an intervention in a random sequence, meaning the first people will group them into group A and then group B. I don't know if we have here, okay, it does not have. So the first group will receive the intervention, and then another group will receive the placebo. And then, okay, after some time, okay, we know we allow after, say, for example, let's say 2 weeks, that you give the intervention in the control and in the experimental, and placebo in the control. Okay, and then after 2 weeks, we wait for a period of time to allow the drugs to be completely eliminated in the body. Okay, so after about half-life, or 5 times the half-life of the drug. So if the half-life of the drug, for example, is 1 day, and then 5 times the half-life, so we'll have a rest for about 5 days, and then after 5 days, those given the intervention at the beginning will now be given the placebo, and those given the placebo will now be given the experimental drug. That is now a crossover. That's why it's called a crossover trial. By outcome, it can also be classified as explanatory or pragmatic. Or an explanatory RCT tests the efficacy in a research setting with highly selected participants and under a highly controlled conditions. So a lot of vaccine trials are efficacy trials. There is very strict inclusion exclusion criteria, and then that's why the participants are highly selected, and then the environment is highly controlled. The pragmatic RCTs tests the effectiveness in everyday practice with relatively unselected participants under flexible conditions, and in this way, pragmatic RCTs can inform decisions about practice, meaning there is not much inclusion-exclusion criteria. There is not very strict. No. we want to look into, and then we want to make the selection of the participants very, very close to what is normally done, what normally happens in a real world situation. So we test the effectiveness, and these are pragmatic RCTs. By hypothesis, we categorize them as superiority trials or non-inferiority trials. And most RCTs are superiority trials in which one intervention is hypothesized to be superior with another. If we are comparing an experimental drug with a placebo, that should be a superiority trial. Some RCTs are non-inferiority trials, which determines whether a treatment is no worse than a reference treatment. So if, for example, you are talking of a drug compared to the alternative drug, okay, so that becomes now a non-inferiority. An alternative drug, I should say, compared to a controlled drug, compared to a standard drug. So we want to look into whether the alternative drug, which is much cheaper than the standard drug, is as effective as the standard drug, or is non-inferior to the standard drug. So that is a non-inferiority trial. Okay, now clinical trials can be likened to a cohort study. As you will note, we told you that in an experimental study, we begin with people who don't have the outcome. In a cohort study, we begin with people who don't have the outcome. In a clinical trial, the outcome will be people these are people who have the disease, okay, both of them have the disease. One is given the experimental, another one is given the placebo. Okay, now the outcome will be people who will be cured from the disease. So all of them still have the disease. In a cohort study, we begin with people without the disease, and we will look into how many people, those exposed, those unexposed, will develop the disease. So there is a follow-up. In much the same way, in a clinical trial, we begin with people, well, here with the disease, but our outcome will be number of people who will get cured of the disease. And because it is likened to a cohort study, you will note that the measure is risk ratio, very much like a cohort study, but then we have an absolute risk reduction, which is again akin to attributable risk. Later on, we'll show that to you. The relative risk reduction, and the number needed to treat, and then the number needed to harm are other measures that we calculate in a clinical trial. And calculation for the risk ratio is the same as that for a cohort study. Okay, so again, we'll make use of this table, the same table that we used when we talked about observational studies. And then this is the formula for the experimental event rate. You will note that this formula is the same as the incidence of the disease among the exposed, except that we now call them the experimental event rate. So number of people with the A and the B are people given the intervention who among them will still have the disease. So the same formula as the incidence of the disease among the exposed. And then this is the control event rate, CER, number of events among people in the control group. The C and the D are people given the placebo who among them will still have the disease. This is the control event rate, or the same formula for the incidence of the disease among the unexposed. And then we get the ratio. So this is the numerator, the experimental event rate, and the denominator, the control event rate. Very much like the risk ratio formula for a cohort study. Okay, now in a clinical trial, we calculate for the absolute risk reduction, the ARR, which is also called the risk difference. That's the difference in the event rates in the EER and in the CER. So this is the formula, CER and EER. We talked about attributable risk last time when we talked about cohort study, and in an attributable risk, the incidence of the disease among the exposed is the minuend, and the incidence of the disease among the unexposed is the subtrahend. Now this is different here. Now the minuend is the experiment, is the control event rate, and the subtrahend is the experimental event rate. We'll tell you the meaning of this. Uh, okay, we'll give you later on an example of an absolute risk reduction, or probably in class we will give that example. I don't know if I still have time here. So we have the relative risk reduction, the difference in the events rates expressed in proportional or in a relative manner in relation to the control event rate. And this is actually the reduction of the risk of the disease in the experimental group relative to the control group. And this is even more impressive than the risk difference, You see, the relative risk reduction is more often used in vaccine trials. Well, it can be used not necessarily in vaccine trials, but in vaccine trials, the relative risk reduction, the RRR, is more commonly known as the efficacy. The efficacy in a vaccine trial is really the relative risk reduction. And the efficacy is many times misunderstood by lay people, even by many doctors when they talk of efficacy. And that is why I don't want to call it efficacy, but I want to call it the relative risk reduction. So it will, the meaning of this will be more understood by people. Okay, so let's look into the formula of the relative risk reduction. This is the formula of the relative risk reduction. Again, this is the CER minus the ER. This is actually the absolute risk reduction divided by in relative to the control event rate. So the absolute risk reduction relative to the control event rate, that is the relative risk reduction. But you can have a different formula for a relative risk reduction, but will give the same results. So in the formula for the efficacy, this is actually the formula that the people in the vaccine trials will use for the efficacy. So this is the formula for the efficacy, which is also the same as the relative risk reduction, and the results will come out to be the same. So 1 minus the risk ratio, this is actually the risk ratio, 1 minus the risk ratio, or 100, if you multiply this by 100%, so that will be equal to 1 or up to 100%, So that's your efficacy. So the relative risk reduction is more commonly known, as I said, as the efficacy, and the formula looks different, but the results will be the same. Okay, so just give you an example of a vaccine, the Pfizer vaccine efficacy. When Pfizer vaccine was first introduced in the market. So there were 21,720 people given the Pfizer vaccine, and there were 21,278 given the placebo. After some, I don't know, 1 month, 2 months, I can't recall now, okay, of treatment, number of people who developed the disease is 8 out of 21,700. So you multiply that by 100, that's equal to 0.0368%. So 0.0368%. Now, among people given the placebo, these are the number of people that developed the disease, and that's actually 0.75, so less than 1%, 0.75 developed the disease in the placebo, and 0.03 in the control, in the Pfizer vaccine. And the efficacy will be 1 minus the risk ratio. This is actually the risk ratio. This risk of the disease among the Pfizer vaccine divided by the risk of the disease among those given the placebo, that's equal to 0.95. And if you now calculate, and that will now be the relative risk reduction. If you use this formula, This is the formula. This is the CER minus the ER. CER, that's the CER minus the EER. Okay, divided by the CER, the result will be the same. The result will be the same. So that means the efficacy of Pfizer vaccine is 95.6.16% if you multiply that by 100. Okay. So the efficacy is 95% means that for those given the vaccine, risk of COVID is reduced by 95% compared to or relative to those not given. That actually is the meaning of the 95% efficacy. So again, risk of COVID is reduced by 95%. That's why it's called that. That's why it should be called a relative risk reduction. The reduction in the risk of the disease, so that's 95% relative to or compared to those not given the vaccine. Okay, so number needed to treat will be the number of patients who would have to receive the treatment for one of them to benefit from it. That's calculated as 1 divided by the absolute risk reduction. Okay, so this is the formula. And then just to give you an example, a study was made comparing the efficacy of oxygenated water in treating moderate to severe acne. Results of the study are shown below. Okay, this is the control event rate. The control event rate is okay, 0.5. Just go back. So 50 divided by control event rate, 50 divided by 100, that's 0.5. And the experimental event rate is 40 divided by 100, and that's 0.4. So 0.5 and 0.4. Okay, the relative risk will just be the ratio of 0.4 and 0.5, and that will be 0.4. The absolute risk reduction is 0.1, and then the number needed to treat will be 10. Now, if the numerator is equal to the denominator, as we said, then the ratio is equal to 1, that's the null value. We'll just go ahead very quickly here because we already have discussed this a while ago. So that's greater than 1. Okay, that's the treatment is deleterious to the drug, or to the disease, I should say. If it is less than 1, treatment favors the disease. Okay, so 95%, we talked about this when we talked about a while ago. Okay. And yeah, I think that's the end. And we'll try to discuss this in class when we meet more examples later on. Thank you.